voice. I picked up a little bit of a cold over the weekend. Dr. Pino, I'm sure you were healthy and enjoyed the Super Bowl. I know you're a big sports fan. Um, and today we're going to be talking about really, which is seems to be the new thing in psychiatry, and that's the use of psychedelics in treatment for depression and other mental health and mental illness issues. And I think, doctor, if you could, I mean, first define what is a psychedelic. What differentiates that from any of the other medications out there? And I know currently, right now, they're not. None of those substances are accepted by the FDA, so they can't even really be considered medications. Could you just clear that up for everybody?
Well, yeah, I mean, psychedelics are not a new thing. Psychedelics have been around for a very, very long time and have been used in psychiatry in the past, both experimentally and clinically. However, when we tend to hear the word psychedelic, we tend to think about illegal drugs. We tend to think about psilocybin, mushrooms, ayahuasca, LSD, ecstasy, and there's basically medications. I'm sorry, substances that tend to get you disconnected from your environment and reality, and they all seem to have a similar mechanism of action in the brain. However, not all the medications that may induce dissociation are necessarily illegal. For example, ketamine. Ketamine has is not technically classified as a psychedelic, but in terms of mechanism of action, it has similar qualities, right? And the issue of dissociation is something that can be provoked by substances or is something that can actually happen, right? People can get dissociated without medications. And basically, what happens is that the ability of the brain to block stimuli gets limited. So we have parts of our brain that regulate how much input we get allow into our brain, right? So when you start affecting the gate, I mean, some people would say the thalamus part of the brain, and that part of the brain gets affected, then things start getting bombarded. So your experience may be very different, right? Now, for most people, that can be a relaxing, enlightening experience. For some other people, it may become a frightening experience, and really depends a lot on the individual, your physical state, your mental state, your experiences, and so on. Because once you start affecting the gates, you basically start affecting the ability of the brain to regulate. And different parts of the brain have different effects.
So, when ketamine is more of a dissociative, what are the psilocybins, ayahuascas, and things? Are they essentially the same, or you said they're different? But how specifically are they different?
Well, they're different because they're not as purified, if you may. So the effect on the brain may be more global. You know, ketamine was developed as an anesthetic because it puts you down. It can take you into a state of that you don't perceive feelings, right? For example, surgery, things of that sort, physical type of feelings. Now, these substances may tend to be a lot more global, and there's a lot of work going on by different companies trying to refine the parts of those natural substances, like on the mushrooms or LSD, to try to identify specifically which are the areas of the brain that have the most impact when it comes to psychiatric treatment. Because what we have learned is that probably the two more studied one has been ketamine and psilocybin. They have a pretty significant effect on reducing the intensity, frequency, and dysfunction related to depression, including suicidality. They also seem to have an effect on reducing the memory experiences that you have in post traumatic stress disorder. They tend to reduce anxiety. And there's a lot of really fascinating data, particularly in ketamine and psilocybin, on reducing impulsive drinking, right? So there's a whole new realm of experience with these new substances that provide us with new tools, right? Now, what most people don't understand, and that kind of became evident recently when there were some articles about fluoxetine, Prozac, and SSRIs as a treatment of depression, and is that up until now, or up until recently, a lot of the emphasis on the research looking for substances to help people with depression, anxiety, PTSD, and so on, bipolar disorder, were based on a theory that is like 75 years old,
Mm,
meaning the theory of serotonin, dopamine, norepinephrine, ACTH, right? So for a long time, we were kind of blinded by those theories, and we were chasing those theories. And we ended up with a lot of Me Too like drugs, right? A lot of SSRIs, some SNRIs, but all around that concept. Now, they became the standard of the treatment of depression, right? So when we start using, I'm sorry about my dog that's behind me. Anyhow, when we start getting into measuring the effect of these substances, what we tend to do is to compare them to the SSRI. So there
mm,
was, I think, last year a fairly large study done in the UK on the use of psilocybin for the treatment of depression. And what they found is that it was as effective as SSRIs, right? But also the remission rates, and that's actually a research technical term. Remission means that you don't have any symptoms of depression, right? That you're as miserable as everybody else without being depressed. Not necessarily that you're happy. And then you have the remission rates were probably 10, 15% higher. So that was an observational study,
mm.
but it is a comparative study with the SSRIs, but it was not placebo control. And the standard in the United States to approve drugs is placebo control study. So we're still far away from that, but I can tell because of the research that we do, there's a lot of interest on psilocybin-like substances, ketamine, isomers, and different substances that can facilitate what we call escaping from depression, right? Because depression, and we were talking before the program about this, is a pretty serious public health issue, right? I
Mm.
mean, is a number two cause of disability in the United States today after uh, heart disease, right? And soon to become number one. And after the pandemic, the incidence, prevalence, and diagnosis of depression has become very, very significant, in particular with teenagers. I mean, I'm a teenager treatment physician in terms of severe illness and hospitalization. So in that sense, for me, it's very interesting to find other tools. Okay, not because I think that pharmacology is panacea. I don't think, and we've said this before, medication at best reduces the intensity of your symptoms and facilitates your recovery so you can do what you need to do, meaning having the energy, the motivation, the interest, and decreasing the thoughts of life not being worth living. So if we can achieve that with whatever substance, that becomes important. And I'm particularly interested on these medications, ketamine and substances like psilocybin, uh, in that I am very focused on reducing suicidality, which has become common as an epidemic. And we do know that when somebody is acutely suicidal, we can get them out of the depression if they respond well fairly fast. I mean, we're talking about a week versus 2 to 4 weeks with the traditional medications.
And what's the process that does that? That's significantly different from the SSRIs and SNRIs.
That is still up for
That's part of the
grabs.
study. That's part of the study.
Well, what happens is that um, people who are, I mean, scientists that are a lot smarter than me are breaking their heads on trying to understand the minutiae of what happens in the brain, with a complication that the brain is tremendously complex, right? So you can push on one side and another side pops on the other side. So when you start looking at the multitude of computers and connections between those computers inside of the brain, it's not simple to understand, even though there's some ideas, you know. But what we do know is that these substances tend to facilitate uh, the growth of better connections in certain areas of the brain, but at the same time, they're turning off other areas of the brain. So it's like they're switching things to some degree. We're also very interested in the effect of ketamine, for example, on memory imprint, especially in trauma. You know, that PTSD is kind of like a complicated recurrence of bad imprinting in the brain.
Hmm.
And apparently, ketamine, if you use it early enough in the trauma process, may facilitate reducing the amount of bad imprinting in the brain, so reducing the flashbacks and the nightmares and things of that sort. So there are a lot of different things that are still up in the air, and probably ketamine is the one we have the most experience. At least we've been using it for the last 6 7 years. As an infusion, there's some new ways of doing ketamine now. Lately, there's a new way of doing it with a sublingual ketamine tablet that is you can actually do it through telemedicine. You don't necessarily have to have the patient having an IV. So there are new things coming out. There's um, Spravato, which is an inhale ketamine that is difficult to obtain and get the insurance companies to pay for because of the restrictions for certain types of depression, but it is available. So we have better tools today than we used to have.
So, of the ones you've mentioned, I mean, ketamine, psilocybin, which are the mushrooms. What about ayahuasca, DMT? What's the other one? LSD, even? I mean, what are we talking about? Which specific ones, other than those two, are being looked at now for psychiatry?
I have to say that they're all being looked at. However, there's two ways of looking at this. One is when you start using it as an experiential process, meaning in their clinics in Central America and South America, where you can go to the clinic and spend a couple of weeks there. It's like a resort. You get uh, sessions with ayahuasca or some other psilocybin or whatever the substances they have in that particular clinic, but the experience gets borderline. Um, how can I say it? Borderline spiritual, right? So when you start talking about therapy or philosophically guided sessions, you're moving away from just the science of the drug, right? Because you're introducing other factors. And what happens is that a lot of people think that the therapeutic effect of psychedelics or ketamine is a dissociation. That is not the therapeutic effect. As far as I'm concerned, dissociation is kind of a side effect, right? Because what we see in terms of the improvement of depression, energy, motivation, concentration, decreased suicidal thoughts comes after the dissociation. So if I could give somebody ketamine without dissociation and help the depression, I really consider that a success, right? But when you start getting closer to the spiritual, you know, transcendental type of experience, then the transcendental dissociation experience becomes more important than helping the depression, right? So
Gotcha.
there is this idea that you could do some inside, in-depth psychotherapy when somebody's defenses are withdrawn because they're experiencing their sensory experiences are different. And that's not necessarily true. That's not the goal of the treatment. The goal of the treatment is to introduce a substance that is going to have an effect on the brain that is going to reduce the symptoms of depression, anxiety, PTSD, alcoholism, but it's not measurable in the context of how much dissociation you got.
So, what do you say to the people who say, "Oh, these are just party drugs. You're replacing one addiction with another. Just because it comes from a plant versus a pill, that it's hocus pocus." What do you say to those people?
Well, number one, they are party drugs. There's a whole scene in the environment that we have to be vigilant for in terms of people using this for the dissociative auto reality experience that you get from them. So that is something that we have to be very, very vigilant. Then when you get into research, the DEA is very vigilant with those things. Psilocybin is still um, an illegal drug in the United States and Canada and probably the rest of the world. So we have to acknowledge that. So we have to work in the context of those things. Ketamine used to be called Special K. Kids used to steal it from veterinary offices, right? So these are serious substances that we have to be monitoring, right? And we shouldn't be selling the idea of people go get a dissociative experience is going to help with your depression. That is not the purpose of this. But we do know that people who have infusions of ketamine and have experienced microdosing of psilocybin or some trials of LSD get better from depression, and they get it better from depression because of the changes of the brain, not because of the dissociation. Also, we have to keep in mind this dichotomy that we always work with. Is the patient unwilling or unable, right? Especially when it comes to substance abuse. We're always saying, well, he's just a drug addict. He doesn't want to stop using. And I always have to raise the question is, if I do a good assessment, can the patient stop using?
Mm.
And if the patient lacks the ability, whether it's biological, psychological, and social, we have to strengthen those parameters, strengthen the biology, the psychology, and the sociology so that individual have better tools, right? And that is true for people that suffer from mental illness in particular. They're very vulnerable to abuse of drugs. But in a lot of cases is because the inability of the brain to facilitate their will, right? So we have to always keep that in mind because it's not as simple as saying, um, let's have him stop using drugs. I mean, when I talk to my students, I'm always telling them, listen, if you have a patient with schizophrenia who drinks alcohol heavily, right? Don't send a patient with schizophrenia to an AA meeting because they don't have the cognitive capacity to sit down to a meeting and interject and process, okay, in a rational way, you know, your problems and the 12 steps and all of that. You have to find another way of maintaining that individual occupied, get rehabilitation type of processes, get cognitive therapy, cognitive improvement rehabilitation, so they can have better tools, right? But AA by itself may become a delusion for them. So you have to be very careful using these mantras, that everybody who drinks should go to AA and that's going to help them drink. Well, not necessarily, right? And so we're looking at this differently now in terms of how is the addiction process complex from a biological, psychological, and social way, so we can facilitate, the individual functionality. Unfortunately, we've always thought of treatment in the context of absolutes: depression, no depression; alcoholism, no alcohol; drug abuse, no drugs, right? But we need to find what is it that is making the person dysfunctional, because at the end of the day, the best way to measure improvement is not by the attitude of the individual, but by the functionality of the individual and their ability to be balanced and content.
So you mentioned that you are going to be part of some of the research coming up. Could you discuss that a little bit?
I can discuss the fact that we are going to be to Reverie Mind, and you guys can go to reverymind.com. We're very interested in psychedelics and ketamine. We're also very interested in facilitating recovery of opiate dependence on, particularly in kids. I mean, we have had 70,000 suicides, probably half of those under the age of 18, and we want to make sure that they stand a better chance. We're looking at two substances now. One is coming from Canada, and is a similar drug like psilocybin, but is actually a medication. And we may start doing some studies in OCD for that. And we're looking at some other substances in the context of the function of the brain. And we're trying to get ourselves connected with a pure psilocybin study. Um, so, I mean, we're in the process of doing that. You have to get a special licenses from the DA and things of that sort. So you can imagine having to store these things and having them on site and things like that. So we're working on that. But I have had a number of patients who have procured and secured these substances on their own,
Mm.
and they have, I mean, I have to tell you, patients that I've treated for 20 years for treatment resistant depression, in which we have tried everything. In one of the cases, including ketamine, did not respond. It did not respond because the dissociation was too intense and frightening for the patient, not because he didn't have enough of the infusions. But with microdosing of psilocybin, he basically went back to basically normal. And
Mm,
it's really impressive to see that, and it's very humbling, because when you're a physician and you've been doing this for as many years as I have, um, you end up believing that you have an answer for everything, but we don't, right?
mm,
So we have to be more open-minded and humble by the fact that sometimes we have to learn from our patients, right? And that we have to not judge them, because it's very easy to say, well, you're a bad person because you procure psilocybin on your own and you've been microdosing it. So that makes you a bad person. And we had to stay away from that.
Well, it sounds like there's definitely promise in some of these substances, and hopefully we can show the public out there what it is as it happens through maybe your research, but at minimum here on the show. What's the last thing you want to say about these in closing?
What I want to say is that we need to stop being afraid of psychiatric disorders and mental health issues. We have to acknowledge our limitations, but we also have to acknowledge how much these things affect us, right? And how much we can do for ourselves, hence the only you, right? To be honest with ourselves. And if you have lack of energy, lack of motivation, lack of interest, at times you don't feel like getting out of bed, and your doctors can't find anything, you may suffer from depression. If you
Mm,
can't stop worrying, you may suffer from anxiety. If you drink more than 14 beers a week, and it's affecting your ability to get up in the morning and go to work, and you're arguing more with your significant other, and you're yelling at the kids, you need to be honest with yourself and say, this is affecting me. So the best thing you can do is to ask for help, and start by asking for help from the people closest to you. Unfortunately, the ones that are closest to you are the ones who suffer the most serious consequences of your behavior. But there's a reason why they're still there,
mm.
right? And they're not going anywhere, hopefully.
Care, love, and support, and hopefully down the road, some of these substances to aid them on their journey into a more contented life. Once again, doctor, thank you very much for your time, and we'll
Thank
see
you. We'll
everybody
see you
again
next. We'll see you
next week.
next.